we are at CSICon 2019, which is being held at the Ashok Hotel, New Delhi. I'm Dr. Rahul Kotwal from medical team of Macleods Pharmaceuticals, and we have Dr. Dhiman Kahali with us, who has presented a session on primary PCI in STEMI. He's a chairman NIC, convener STEMI Council of India, executive committee member of CSI for 6 years. He is a senior consultant interventional cardiologist at BM Birla Heart Research Center, Kolkata. He is also a program in charge of PG Medical Education at BM Birla Heart Research Center, Kolkata. So, sir, foremost, I would like to welcome you to this channel and to this session. As you have given your session in CSICon 2019 on day 1, so, sir, we would request you to summarize your session for the benefit of the fraternity.
So, today I talked about primary PCI, 10 commandments of primary PCI. So, before talking about primary PCI, what is primary PCI? This is angioplasty done after a heart attack. Now, what is the situation? How many people in our country have heart attacks? To give you the latest data, we have some data from 2017, NIC data presented in the same place in 2017 April, where it was shown that approximately, because we haven't got that much of robust statistics as it is evident in the Scandinavian countries or USA or other advanced European countries. So, approximately 30 lakh people in India had myocardial infarction, and out of that only 12 lakh persons had thrombolysis, that means reperfusion, and another 56,000 had some sort of angioplasty. What sort of angioplasty? Primary or pharmacoinvasive, or it was rescue angioplasty for failed thrombolysis, or rescue angioplasty in a delayed way. We do not know of the details of the angioplasty procedures. So, if you see the global situation in small countries like Japan, Belgium, Netherlands, small European countries, then Finland, the Scandinavian countries, France, Germany, everywhere, and now even in UK, almost 99% plus patients get a benefit of primary PCI after a heart attack, and that too as early as possible. But in our country, unfortunately, we get the patients much delayed. The CREATE registry and the Kerala registry tells that we get the patient after 5 hours. I work in a good tertiary hospital, but our experience is not that good, and we get patients even after 12 hours, after 18 hours, and majority of the patients come late because they either come from a referral hospital or a district hospital, and they land up much later, and some of them or many of them are not reperfused either pharmacologically and not to tell by angioplasty, that is primary PCI. So, we have a very dismal situation, and why it is that the awareness among the general population, even among the elite population, is very small. So, as a convener of the STEMI Council of CSI in collaboration with STEMI India, because in India there is a STEMI program actively going on which originated from Chennai. Now they are spreading to different different states, and I was the organizing secretary of the recently concluded STEMI meeting in India under the auspices of Cardiological Society of India, and secretaries and health secretaries, ministers from 16 different states came, and we are trying to propagate the idea that patients should recognize once they are symptomatic. Immediately they are symptomatic, they should recognize that he has a heart attack, they should go to a hospital where there is good treatment for cardiac diseases. That is the first requisite. So that whether it is reperfusion by pharmacological means or by angioplasty, something is to be done. We are propagating that idea, and from different platforms like Cardiological Society, Indian Medical Association, Association of Physicians of India, we are telling that if the time delay between the pharmacological reperfusion, that is thrombolysis, treatment with drugs, and angioplasty is more than 2 hours, we should go for thrombolysis with streptokinase or with retiplase or with tenecteplase. Reteplase and tenecteplase are newer thrombolytics with 60% reperfusion at 90 minutes in the infarct-related artery and with a much lesser chance of intracranial hemorrhage in comparison to streptokinase. With streptokinase, the patency rate of the IRA is 32%. So, with the newer thrombolytics, it's just double, but the mortality has not been influenced that much by the newer thrombolytics like tenecteplase or reteplase. So, that being the situation, we understood that in majority of the patients with ST elevation myocardial infarction, they go for thrombolysis in almost more than 90% of the patients out of all the patients who are reperfused. Of course, in USA also till now, I am telling you from the quotation of a North Carolina cardiologist who is actively involved and is in the task force of STEMI also, that in USA also 20 to 25% of the patients are not thrombolized or not reperfused following the acute myocardial infarction. But the situation is much better even in smaller European countries. So, we are trying as a whole to increase the awareness among the people so that they recognize the symptom of acute coronary syndrome and STEMI in particular, and they subject to themselves to the hospital instead of going for an ECG in the house or going for a doctor and wasting hours after hours, several hours in the house when the vital things may go down and the patient even may die, because we know among all the mortality which happens following a heart attack, 50% of the patients die before they can reach the hospital, that is during the first 1 to 2 hours. And therefore, we call this first 1 to 2 hours as golden hour. Now, regarding the nitty-gritties of primary PCI, we tell that you do the infarct-related artery first, you do a coronary angiogram. Usually, we take a diagnostic catheter for the non-infarct-related artery. From the ECG, we can know that which artery is involved in the process, which one is the infarct-related artery. So, we take a diagnostic catheter, do the angiogram, and then we take a guide catheter and we do the angiogram of the infarct-related artery site and open the artery. We do not waste any time. So, I personally take LV data also, like putting a pigtail catheter, see the left ventricular and diastolic pressure, because that is very important in immediate and future management of the patient. And also majority of the patient, more than 90% of cases, if the LVEDP is below 30-35 millimeter of mercury, I inject the ventricle to see a left ventricular angiogram and how is the ventricle, and that also excludes presence of mitral regurgitation or VSD, which are very important to be recognized very early, because these two mechanical complication carries a very high risk mortality and morbidity wise. So, these are very important consideration, and as soon as you see the infarct related artery, open the artery, put a stent. We do not want to do ballooning of the artery before stenting, because ballooning causes dispersion of the thrombotic materials distally and microembolization and causing an inferior blush. And in the monitor itself, you can see as soon as you open the infarct related artery, the ST segment comes down in the monitor, then and there you can see. And I inject the artery and I not only see the TIMI3 flow in the infarct related artery, but also the good blush in that territory, because that good blush indicates that there is ST segment resolution and there is good tissue perfusion at the myocyte level, because 50% resolution of the ST segment elevation indicates that there is incomplete resolution, there is TIMI3 flow. 50% resolution of the ST segment elevation indicates that there is TIMI3 flow in the infarct related artery, but there is no good perfusion at the myocyte level. But if the ST segment resolution at the 90 minutes ECG after the procedure, whatever it may be, pharmacological or mechanical, the resolution of 70% or more indicates that there is not only TIMI3 flow in the infarct related artery, but also there is good myocyte perfusion, and which is noticed in the coronary angiogram by an excellent blush. You prolong the injection and you see not only good TIMI3 flow in the infarct related artery, but excellent blush also. So, in all the patients we do angioplasty primary angioplasty after a heart attack, we must look at these things. And we must look at least once in the monitor to see that after the procedure is complete, how much resolution of the ST segment has occurred. Not always we get complete resolution of the ST segment elevation in the monitor in front of us, because it takes some time. Even after you get a good blush, good TIMI3 flow, it takes some time for the resolution of the ST segment elevation in the ECG. So this gives good results, and after the, if you follow up the patient has come with an extensive anterior wall MI, LVEF 35 to 40%. After 3 months you do another echocardiogram and you see the echo. If you are not unfortunate, the LVEF has improved from 35 to 40% to as good as 60%. That means the patient has come with a broken heart to you, but with your good heart, good techniques and good work, you have presented him a normal left ventricle. So this is a phenomenal gift from the doctor's side to a patient, and we always want to give it, but always we are not so fortunate. We do the same job, but sometimes we get significant salvage of the damaged myocardium, sometimes we do not get it, but we should always try for it. Especially the patients who come earlier, that is first hour, second hour, first 3-4 hours, we get excellent results. We can give almost always a normal ventricle, but always we are not so fortunate and the patient has some damage, but we can salvage some amount of myocardium definitely. Now, while doing this procedure, we should follow certain rules we call as 10 commandments. Number 1, we should see that the patient we should go for direct stenting. That's much better. If ballooning is avoidable, we should not balloon. Sometimes, of course, it so happens that even after passing the wire blindly, you cannot see any distal artery. To see the width of the distal artery or to see the length of the lesion, we have to dilate. So dilate with a very small size balloon. Suppose in a normal case, we will balloon it with a 3 millimeter balloon in a 3.5 artery. But you balloon it with a 1.5 millimeter artery, don't go too high and come down slowly. So the dispersion of the molecules distally will be less. Then you give a simple injection, keeping the balloon over there, ascertain the distal artery and put the stent. Don't go for another balloon with a higher size balloon. We don't want to do it. And keep an ACT between 250 to 300 milliseconds. The use of GP2B3A blockers in dealing of the patient during primary PCI is gradually reducing, and we don't use much of abciximab or these molecules. But if you find that the patient has got a huge thrombus load and the infarct related artery is a huge one, 4 millimeter or 3.8 millimeter artery, don't hesitate to give abciximab arterial intracoronary injection. That gives good results, and it has been found in the different studies recently that aspiration has no special role in the in the procedure of primary PCI. Of course, it is not absolutely abandoned in very large artery with very huge thrombus. If somebody does aspiration, it is of equal result as you give abciximab intracoronary. But gradually the status of aspiration has been downgraded after the TAPASH and the test trial data, and people are going more for intracoronary abciximab if the thrombus load is huge and it is non-inferior to aspiration by a thrombectomy catheter. But it has been already also told that there is not much of a difference between intracoronary and intravenous abciximab, but give some molecule, especially the large molecule, the abciximab. It is better than eptifibatide and tirofiban in different studies, and actually we have found in our practice also it is more powerful and stronger in action of causing some lysis of the dissolving the clots, because these are strong antiplatelet agents and give adequate antiplatelets. Load the patient with 350 milligrams of soluble aspirin and 600 milligrams of clopidogrel or ticagrelor 180 milligram. Prasugrel we give after passing the wire. In the Triton TIMI38 also, both the molecules, that is, it was a comparative trial between clopidogrel and prasugrel, and both the molecules were given after passing the wire. And so we should give prasugrel if we want to really give it after passing the wear, or at least after seeing the coronary anatomy, that he needs angioplasty, because if the patient needs bypass surgery and I load the patient with 6 tablets of prasugrel previously, then we cannot send the patient for bypass during the next 6 to 7 days, because the half-life is very high for prasugrel in comparison to ticagrelor or clopidogrel, and it is much stronger than clopidogrel. And a recent study has shown that it is ESAR-5 study from German hands, our center by Adnan Kasrati and his group, that it is better than the this clopidogrel. However, it has been disputed in some other trials in different parts of the globe. So, this being the situation, we load the patient with DAPT, and one very important thing, we give the patient antiplatelet agent, antithrombotic like heparin 5,000 to 6,000 units in the ER only, immediate contact. Some of my friends who refer the patients to me, they give heparin 5,000 along with loading with DAPT in that dose 600 clopidogrel or ticagrelor 180 with soluble aspirin 350 first dose. They give heparin 5,000, and we have seen that the TIMI-3 flow in the infarct related artery is as good as more than 60%, which is equivalent to the thrombolytics, newer generation thrombolytics, and definitely better than streptokinase. And also we have found that the thrombus load is much lower by giving the heparin 1 hour earlier, because we take the patient at 1 hour average on the table in acute MI patients. And we should also activate the STEMI code once we get the news that the patient is coming, and once he arrives we should activate the STEMI code, so that the brothers, sisters, doctors, emergency doctors, cath lab, and the cath lab doctor and nurses should be ready to take the patient. So, once the patient enters, he should be draped and the procedure started. Sometimes we do like that if the patient is very critical, very serious, we don't do the angiogram of the non-infarct related artery. We take a guide catheter, the patient is having a pressure of 60-70 with inotropes given, and normally we want to avoid IABP because it's costly, it puts extra cost to the patient, and some other problems, some other complications of IABP which is inherent with the procedure. So, to avoid that, we directly do the angiogram first of the infarct related artery, do the job, means open the artery, do the stenting, come to the non-IRA artery and do the job. Regarding the multi-vessel stenting in our country, we have been doing multinational multi-vessel plasty from many years. Now the guideline, the ACCHA guideline used to tell, don't do the non-infarct related artery. Even in USA, till few years back, 1 or 2 years back, they didn't used to reimburse the finances for dealing with the non-infarct related artery, but now probably they are doing it after the results of culprit trial, the PRAMI trial, and some other trials have come into existence, and those have definitely shown that we can go for multi-vessel angioplasty if the patient is stable and if the non-IRA lesion is very, very critical. Some suggest that you can go for an FFR to see whether the IRA, which looks anatomically to be tight, is also physiologically significant one, and in that case we can go for it. Now, coming to some of the complications, slow flow or no flow phenomenon during the procedure which is inherent, we give intracoronary adenosine 30 to 60 micrograms several doses. Just I want to tell that what is written in the books, 3 to 4 doses of 30 microgram is never enough, and in dealing with the actual situation of no flow or slow flow phenomenon which occurs in 30% of the procedures, we have to give much larger doses of 60 microgram each of adenosine, and sometimes we have to add sodium nitroprusside 50 to 100 microgram incremental several doses, so that the refractory slow flow or no flow can be dealt with. In patients where the thrombus load is used, we use intracoronary abciximab. But even then sometimes we cannot overcome the slow flow or no reflow phenomenon. You will find you have given 1500 micrograms of adenosine and 300 microgram of sodium nitroprusside, but the slow flow is as it is. In that case, we give intralesional, means within the lesion the same molecule, and it works like wonders. Believe me, it works like wonder. the flow is normalized, there is TIMI-3 flow immediately after 1 or 2 shots of 60 micrograms of adenosine, which we are not achieving after 20 doses of adenosine. So you can try, guys, with intralesional injection of adenosine 60 micrograms 1 or 2 doses, and it works well, and there is TIMI-3 flow re-established. If it doesn't work, you can give additional dose of 50 to 100 micrograms of sodium nitroprusside, but it is rarely needed. So intralesional injection of these molecules, especially these 2 molecules, work wonders. Sometimes before starting the ballooning or stenting, we give intravenous nicorandil repeated doses, say 6, 7, 8 doses. It doesn't do any hypotension, any tachycardia, insignificant tachycardia, but it works very good. Once you dilate the lesion, you don't find the this slow flow or no flow phenomenon. It's really problem, and all of us should know how to overcome them, and not only overcome them, in 100% of the patients we must ensure that we have overcome it, because unless we overcome it, the patient is not going to give benefit out of the procedure after spending so much of money. So I can tell with all the authority that in 100% of the patients we can overcome the slow flow or no flow phenomenon if we go through all these maneuvers. So intracoronary or intralesional adenosine 60 micrograms several doses, intracoronary sodium nitroprusside if needed, or papaverine or verapamil, and intravenous nicorandil, because in our lab we have stopped using nicorandil intracoronary because consecutively in our lab, after injecting nicorandil intracoronary, the patient had lethal ventricular tachycardia. Eliminate to the use of intracoronary nicorandil, so we no more use intracoronary nicorandil in our lab. However, we should remember that intravenous nicorandil is a second-line drug and not a first-line drug. So one must know before doing primary angioplasty that how to overcome this complication of slow flow or no flow phenomenon, because it's very common, and 1 in 3 patients we get this complication. Sometimes the patient is pregnant. It is a real problem because the radiation during the procedure to the fetus, of course we can prevent it by giving a lead cover over the fetus, and secondly the adverse effects of the drugs. Heparin is the best anticoagulant in this situation, and aspirin and clopidogrel are told to be very innocuous or has got minimal side effects in patients with acute MI. Sometimes, just today I showed one patient, I cannot show it over here, one angiogram from a 42-year-old lady who came with an extensive inferoposterior wall MI due to a huge RCA dissection. This is, spontaneous coronary dissection, SCD as we call it, and it is a long dissection starting from the ostium up to middle to distal third junction, and after we didn't do anything, we did conservative medical management, and with that the patient improved, because it has been seen that in spontaneous dissection, coronary artery dissection, conservative medical management and stenting, or some cases CABG is also required, gives similar output so far clinical efficacy is concerned. So we should treat the patient with high dose of statin, standard DAPT, and stabilize the patient with initial medical management. In cancer patients, it's a problem, and we should always do all these primary interventions to the radial route, and we should always, because the vascular complications such much less, and we give different cocktail of molecules after initial loading, so the chances of hemorrhage is much more through the access site, and we should always try to go through the radial route instead of the instead of the femoral route that reduces the vascular access site bleeding and other complications. And also regarding the choice of stent, we should always use drug-eluting stent from the different trials, COMFORT trial, EXAMINE trial data, and also NORTH-STENT European data, that this stent is definitely, drug-eluting stents are definitely better, and that too the recent, the latest drug-eluting stents, because the use of DAPT may be shortened. You have gone through different papers that single antiplatelet agent may be started as soon as 1 month after the procedure. In this connection, I want to tell that choice of DAPT or how long it will be given, more important is deployment of the stent. Sometimes we have deployed the stent very well and the patient has stopped, not to tell DAPT, but single antiplatelet agent, even aspirin 75 milligram has stopped because he had or she had some acidity problem. So this is Indian scenario, and we had the we are lucky to see the results after 11-12 months. When they came to us, we didn't check angiogram, and in almost all the patients we found the stent to be intact without any thrombosis. So not only DAPT or the duration of DAPT or the choice of DAPT or single antiplatelet after 1 or 3 months of DAPT are important, but it is equally important that the procedure should be picture perfect.